Welcome to our seminar. It is my pleasure to be able to introduce today's speaker, Hallie Jimison, and we have talked with her quite a few times over the past years because her research lab has been some of the pioneers in this area of using technology to assist with assessment and intervention that accompany the challenges of aging. And so I know, even though it's written in her bio, that Dr. Jimison actually worked earlier at Oregon Health and Sciences University because that's how we first became familiar with her work. But now she is faculty at multiple places. She's contributing to the group at Northeastern, but she's also a visiting professor at UC Davis working on the Healthy Aging in a Digital World initiative. So she has much to talk about from all these different projects. And I will turn it over to you, Hallie, to talk about informatics advances for personalized health interventions.
Great. Well, thank you so much. I'm so pleased to be here. I've been a fan of your work and your group. And let me just get started with the slides now. One sec. There we go. So as Diane said, I'm at Northeastern, both on the East Coast and Boston, but working also with the Bay Area group. We have a couple campuses in the Bay Area, San Francisco, San Jose, and the New Mills College. Now, I know this is preaching to the choir here, but I always want to start off with a little motivation and why it's so important to think about informatics approaches in improving and innovating in the space of new models of healthcare. So you're well aware of the aging demographic and rising healthcare costs, but I also want to emphasize healthcare disparities whenever we think about new technology interventions. And the opportunities are so rich, growing opportunities in ubiquitous mobile technologies, even among older adults, minority groups. A lot of times you'll see the adoption of smartphones growing more rapidly under low income and minority groups because there's no kind of legacy systems that are holding people back. And this is true in a variety of countries. So we're looking also at sensor improvements. Sensors are smaller, cheaper, wearable. The battery life is so much better, but still room for improvement, of course. And then the many advances in machine learning and big data approaches. So, and again, as a reminder, many of you are working in this space, so you know how important addressing health behaviors of individuals. But many times, when I'm talking to clinicians, we'll see that the focus in clinic visits doesn't really address these issues very well. When we look at this pie chart on the left, we'll see that medical care deficiency only accounts for about 10%, whereas behavioral is 40%. Genetics are substantial, but still don't overwhelm the need for a focus on healthcare behaviors. Now, I'll go through a wide variety of types of interventions that we've worked with over the years, with a focus, though, on cognitive monitoring and cognitive health interventions. When you think about, or at least our work until now has really focused on addressing the needs of older adults and those with neurological problems or chronic conditions, where most of the care actually happens in the home over the continuum. So when I've done a needs assessment with older adults, I've found that their cognitive health is of utmost importance because they want to maintain independence and typically want to age in place. Now, many of the interventions that are used for disease management approaches are holistic and applied in each of the various diseases. But for cognitive health, physical exercise is probably the most important kind of information and intervention that you can give. Sleep, though, is also very important. Socialization, really underappreciated. It affects all. Loneliness is a risk factor like smoking, on par on that level, and it affects all organs. Medication management has to do with cognition. We've worked quite a bit in the area of cognitive monitoring and interventions for cognition. And then moving around the circle, safety issues are a result of poor cognition, and then stress management and mood management. So we've worked in this space, and I'll go through a couple of examples where we take sensor data from the individual, from the home, analyze patient state, and provide just-in-time tailored messaging. And this is familiar to your group, of course, but what I'm trying to do is put in your mind right now the wide variety of types of sensors that are available to you when you think about working in this space, and it's important to realize what you can take from what's commercially available now or build upon it. And so the typical wrist devices that so many of us have, the Apple Watch, Misfit, Fitbit are the types, and the Oura Ring is another one that has a lot of high quality sensors in it. But you're looking at accelerometers, gyroscopes, and then the inferred number of steps, or whether they're on the elliptical or whatever, heart rate. And if it's a good quality, you get heart rate variability, which is going to be very important for stress management. Electrodermal activity is basically skin conductance, but that's another independent indicator of stress. Temperature, there's a wide variety of sensors that can be fit into watches and rings. Clothing is another area. You get better measurements for cleaner data for heart rate and heart rate variability. Be aware of the tattoos that are used, or tattoo-like sensors that go on the skin for glucose monitoring. If you're interested in gait, you can get sensors in shoes. And of course, maybe it's not so unobtrusive, but there's new work in brain-computer interfaces. We've also worked a bit with a variety of robots, and the double telepresence robot shown here. There's oxygen saturation sensors, blood pressure sensors, Bluetooth enabled, the toothbrushes that are Bluetooth enabled, and that might be something you're not thinking of as being very important. But I've been convinced by working with nurses in this area, what people that specialize in oral health, that again, this kind of bacterial infection can affect all organs, and that it's a very simple kind of intervention that builds upon others. If you have a holistic approach, you might want to include Bluetooth enabled toothbrushes. We've built our own and had a variety of types of interventions there. And of course, Bluetooth enabled weight scales, very critical for any patient with heart failure, where they need to have careful weights taken every morning in the same condition, and anticipate fluid retention and keeping people, very important for keeping people out of the emergency department. So, and just quick reminder of how many sensors are in the phone itself. Accelerometers, gyroscopes for orientation. You can do gait analysis. We work with one researcher who puts, for Parkinson's, the phone on the leg and is able to infer gait measurements from that, or linking it to a place on the trunk. GPS can be very important. GPS from the phone. Sometimes location is important to give you an understanding of context, which then affects how you analyze other data. If you understand context, especially for something like falls, you know when they're near steps. You know, are they just sitting down because they're in a location that has a chair? You know, a lot of times there's so many false positives with fall detection that this is an important area for using context to the best of your ability. GPS for understanding, say if you're trying to help somebody avoid fast food restaurants or avoid a smoking location or where cigarettes are sold, that can be an important variable there too. Now, light level, that's in the phone as well. That can be used for sleep quality. The camera's been used very recently by many people to get have an adapter where they can get high quality electrocardiograms. You can quickly get pulse, oxygen saturation. There's some very advanced algorithms now for mood detection looking at the face. We have one project where we're using a commercially available system called Solo to classify mood so that we can adapt our socialization intervention with music and games for, in this case, we're working in a nursing home, but there are algorithms out there that you can build upon. Either start your own, there's so much opportunity in this space, but take advantage of what can be done with the camera on the phone whenever people are using it. You might think that it's important to have routine use, but so often, if this information is unobtrusive and you're able to collect it routinely, you can modify and have dynamic algorithms that use whatever's information is available, fuse the information from a variety of sources, find out which ones have the highest reliability, and then improve your detection. Now, getting towards the bottom of this list, the microphone provides you with voice affect to help you classify mood in real time. You can detect slurred speech, and we're even working on writing a grant with Stanford right now on using phone voice statistics to detect chronic obstructive pulmonary disease, COPD. In fact, not only detect it, but use within subject trends to try to prevent exacerbations. Again, trying to keep people out of the emergency department. And of course, the phone has temperature. And if you can access the web, you're able to get air quality and a variety of sensors. So what's important in this type of work that you do is that the patient or the user is always at the center of your design. In our case, we're quite often working with older adults. So the sensor data comes in, goes through our inference algorithms. We infer patient state, generate tailored messages, and then have interfaces for formal and informal caregivers, family members, and clinicians. So the opportunities that arise now is that you have data, streaming data from unobtrusive sensors, and of course that can be very complicated and intensive for analysis, but you can assess activities of daily living from the motion sensors or cognitive monitoring with data from a variety of sensors that I'll give examples: the motion sensors, computer interactions, phone data, text, voice. And then there's examples of assessments through interactive systems like cognitive computer games or interactive video exercise. And then finally, opportunities for computer science and computational modeling occur when you're trying to understand patient state dynamically. As data comes in, you update your assessments, and that in turn allow you to tailor your health coaching advice, recommendations, motivation, and linking to patient states, not only physiology, but their motivational state, their readiness to change. All of the health behavior change variables that are so important in making these interventions successful. So some early work that Misha did, Misha Pavel, who's also, we were both co-founders of Orcatech, the Oregon Aging and Technology Center. And this early work took simple motion sensors that were placed in each room. And he's shown that you're able to detect legitimate pathways and make inferences about activities of daily living. And I realize this is an area that your group has been working on tremendously and made a lot of progress as well. So what I wanted to start with, though, was the many opportunities that we have with just very simple sensors. And looking, one of the most important neuropsychological tests just has to do with simple motor speed. And there's remarkable inferences that can be made with this type of data. We can look at speed of walking, computer mouse movement, interactions with, typing speed on a computer keyboard, or interactions with your mobile phone. Can look at gait analysis, linguistic analysis, the unobtrusive data that you can get from the phone or from any word processing type of data on the computer or phone. And then there's moving from simple sensors to adaptive cognitive computer games, which we'll go through a little bit later. And these are adaptive in the sense that they are tailored to individuals. And then more interactive is the interactive video exercise, where cognitive data can be extracted from that as well. So some of you have already seen this, but I think it's important to start out with what can be done with the most simple types of sensor data. In this case, there's simple motion sensors that are put in each room. The dots are color-coded by location, where green is the bedroom, red is bathroom, etc. And you'll see in this polar plot, day one, it's a year's worth of data for one individual, where day one is in the center and 365 degrees days later is on the outer ring. Midnight's at the top, noon at the bottom. And you'll see this individual has a good quality of sleep during the night, typically goes to bed around 11 o'clock, but there's a lot of variability. Wakes up typically around 7 o'clock. The data was very clean, very few sensor triggerings early in the first half of the year, but suddenly the sleep quality got more noisy, reduced sleep quality. But you can learn a lot about this plot. You see that she's in the kitchen, breakfast, lunch, dinner, not exactly at the same time every day. And if you had to think about safety alerts for this individual, you'd have to take into account the high variability. But when we compare it with another subject, again, one individual, day one in the center, 365 degrees later, or days later at the outer ring, you'll see sleep quality was fairly poor throughout the full year. This person doesn't go to bed at any particular time. It's very sporadic, but wakes up very, very reliably around 7 o'clock, gets into the bathroom, gets ready, but then goes out for breakfast, lunch, dinner. That's because this individual lives in a senior facility where you go to the cafeteria for meals. So this kind of pattern, you'd have a very different threshold for when you would alert a family member, and then more typically onto clinicians or the management at the center. So having adaptable alerts has become a very hot topic in research. And it's so important that we don't over alert and get people deciding not to use our technologies at all. So early work in walking speed was simply putting these motion sensors in a hallway. We would tape them for restricted field of view to get a more accurate speed measurement. But then simple walking speed, we're able to compare with measurements that are taken in clinics and standard neuropsychological tests, where you walk a certain distance, like 15 feet back and forth, and that measurement is assessed and looked at in comparison to all of the other types of neuropsychological tests. And so this is one metric that contributes to an assessment of cognitive function. And what's become really interesting is that the early work on this has shown that we are able to detect this kind of decline in walking speed and anticipate much earlier a diagnosis of MCI, or mild cognitive impairment. You'll see that the decline is far more rapid than you would normally see with just slowing due to normal aging. And this can really be best detected by looking at within subject trends. And I should say this is time on the x-axis and the speed of walking on the y-axis. And it's a heat map where the warm colors are the peaks of the distribution. And what's so interesting, even though they're walking in the hallway, there's high variability in walking speed any one day. You wouldn't want to make a diagnosis on that kind of variability. But when you look over time at within subject trends, this is accounting for any kind of arthritis or something that would have a different kind of time history. But within subject trends can be so much more valuable than trying to compare people to a population. In this case, over again about 3 years, you'll see that there's not a real decline early on in the first 2 years of walking speed, but this does detect a stroke that was clinically verified in this one example. Again, this is one person. And so you'll see the walking speed declined around in the third section here, and then came back up, but never to its original speed. But what's interesting to note, there's so much more information in this kind of walking speed measurement, where you see that something similar happened earlier and was not clinically detected. So this is a ripe area that I would encourage more people to start working in. Now, when you think about motor speed, another neuropsychological test that is used is the finger tapping test. And that's where you see in the upper right corner, the subject is asked to tap on this device as fast as they can, and it measures how quickly one can tap the finger, and that is another area of motor speed. And we were able to do studies where we would look at the correlation between how fast somebody could tap on this finger test, and that would be on the y-axis, versus their typing speed on the computer. And it had fairly high correlation. And this could be done within subject, looking for trends, as opposed to coming in once a year for neuropsychological test. It's another separate measure that's unobtrusive, that can give an indication of problems with motor speed. So what I'm trying to get at here is how important it is to use whatever information's at hand to be able to combine and give you better estimates as time goes on, and the big importance of using within subject trends as opposed to comparing to a population. Many of the neuropsychological tests, not the motor speed ones as much, but neuropsychological paper and pencil tests are very culturally biased. They try to correct for education level and a variety of other factors, but your experience with these types of tests can make a big difference. So another independent, another separate kind of motor speed test with unobtrusive. As people use the computer, they're using their mouse. We were able to show a very nice correlation between mouse movement on active moves versus, for example, the very important trail making test. So what's plotted here on the right are the speed, the cursor velocity on the x-axis. And then this is a distribution then of the frequency of finding these velocities. And you know, when you use a mouse, a lot of times you're just kind of hovering and browsing, but we were able to separate these kinds of browsing moves from active moves. And the peak of this active move here is what we estimate and try to correlate with our trail making tests or standard neuropsychological tests to give yet another indicator of movement as it's collected. And you never have to ask people to do a test. You're just unobtrusively monitoring this. So these are examples of very simple types of data that can give additional information on cognitive performance. So other opportunities to think about. Linguistic analysis. One thing that you can look at is the complexity of somebody's writings. And the example that I just love is Iris Murdoch, this famous English novelist who wrote many books, had very little influence from editors modifying her writings. She eventually passed away from Alzheimer's, but it was detected very late. Now, if retrospectively, researchers went back and looked at the complexity of the language in her work and found that there was a slow decline, even though her very last novel was very successful. So one of the problems with people that are highly educated or very talented and cognitively active, it's going to be harder to detect cognitive problems because they can compensate and aren't going to be helped early on with any of these new drugs. One of our goals is to do early detection, even for people that are doing fine, because what you'll see in more highly educated, cognitively active people is that they will drop off very precipitously in their abilities. Now, linguistic analysis, just as an aside, is also very useful in schizophrenia and depression. There have been some interesting work on being able to detect, diagnose schizophrenia, and also look for episodes of schizophrenia by people's writings. The linguistic analysis, it's not complexity, but there's algorithms that you can see in the literature, both for schizophrenia and for depression. Voice analysis itself, just taking the voice statistics. I mentioned before, depression is one, the pitch is lower, the speaking gets slower. Parkinson's is pretty clear. You know the sound of Parkinson's voices. And then I did mention the new work on chronic obstructive pulmonary disease. So then finally, if you think about your opportunities in just looking at movement, GPS, and just general usage of technology can give you indications about a person's level of socialization and depression itself. So a lot of the work in trying to anticipate episodes of, for people with bipolar depression, episodes of depression versus increased rapid activity has been a useful predictor and helpful with medication monitoring. So just to kind of the main points that I want to get across with regard to modeling cognitive function using home monitoring data are that you can use this kind of information to manage neurological conditions. A lot of people aren't thinking about, they're thinking about diagnosis or knowing screening, knowing when to alert a clinician, but it's also useful whenever you're trying to manage or look at the effectiveness of an intervention. So an example would be monitoring recovery from stroke or for traumatic brain injury. But again, most of the focus has been on early detection of cognitive decline. So just as a quick review, the data sources you can use are motion sensors in the home, computer interactions like typing speed, mouse movement, looking at phone sensors, cognitive metrics that are embedded within adaptive computer game. And I'm going to talk about that next. And the main point that makes this so important, this kind of approach compared to the standard clinical tests that are done, is that by making it unobtrusive or whenever it is obtrusive, at least it's in the home, it's in a natural setting, and it allows us to have within subject trends where we're looking at trends that can be much more sensitive than an absolute metric that is compared to a population. Another valuable part of this is that we are also able to measure day-to-day variability. One of the hallmarks of cognitive problems is that people go in and out of lucidity, their performance changes, and this kind of approach really provides a framework for the clinicians and care managers to manage patients in the home, but also detect cognitive problems early and get, perhaps we're hoping for new drugs early on. So a little bit about cognitive computer games. And this has been a favorite area of mine, where we started out years ago when we were in Oregon and have been working on cognitive monitoring for quite a while now. What we did was to develop a suite of cognitive computer games for older adults, casual computer games, because we did needs assessments and surveys and usability testing to find out what kinds of games people like to play anyway, and then figured out ways to best put in are algorithms that would make inferences about cognitive function within the games. So one of the first games that are fairly, obvious and easy to imagine how this would work for measuring memory, working memory, is we called it on the flip side, but it's usually called the memory game or concentration. And that's where you make matches on a set of cards, and you have to correct for chance behavior, but you can make the challenge more or less difficult to match and keep your individual older adult motivated. You want people to be successful and yet challenged without being overwhelmed. So in this case, this is work that Misha Pavel did, and I'm hoping that when he gives a talk next week, that he'll be able to talk about some of the modeling here. But by taking an estimate of a person's ability to remember a card placement and value in order to make a successful match, again, correcting for chance behavior, we can plot a survival function, a typical Weibull survival function that's used very frequently in clinical trials. And what Dr. Pavel has labeled this a memory buffer length, because then you can summarize an individual's performance over time by a single memory buffer length metric and look to see how this metric, individual metric, changes over time within subject again. Another cognitive computer game that we use, and this was worked on by one of my students in Oregon, and that is a two-dimensional blackjack game. And what we measure here is not how well somebody plays blackjack, but our metric had to do with, could they be successful on both rows and columns at the same time? So it was a game people like to do, but what we were trying to get at was this very important measure of divided attention. It's one of the first things to go as people age or develop cognitive problems. So there's also, of course, room to improve divided attention with practice. But as I'll talk about a little later, it's so important to make sure these kinds of skill sets actually generalize and become useful in routine daily life. One of our most successful games at predicting the important trail making test was called Scavenger Hunt. Now, first I should explain what trail making is. Most of you know this, but it's the paper and pencil test that has 26 circles on it. And the simple A form of the test is just connecting the numbers in order. The more complicated B form of the test asks the individual to link in order numbers and letters. So you go 1A, 2B, 3C. Now we're able to, in our target screen at the top here, where it says B2A1, that would be the sequence we're asking people as quickly as they can to select those letters and numbers in order. And in order to look at a more motor speed type of activity, we would do 1, 2, 3, 4 without any distractors. You'll notice there's only 4 targets and additional distractors here. So we can change the complexity of this string here from something as simple as 1, 2, 3, 4, or the word horse, or something like that, to a more complicated more difficult to remember string. And what makes that really interesting is that when we get to the modeling here, we first separate out the amount of time taken to recall the next target from the searching for the next target, which would be dependent on the number of targets and the number of distractors, and then the simple, how long does it take to move to the next target? This will give us a very nice correlation with our estimated or modeled trail making score with the measured, when we actually measure trail making in the conventional way with our participants. So down here, the circles represent the simpler 1, 2, 3, 4, that trail making Trails A test, where we estimate for each individual how well they would do on Trails A, and the plus signs are the Trails B results. This kind of R-squared never looked great to engineers that we talked to, but when we tell them this is very comparable to just test reliability, psychologists are more impressed. So one thing I want to emphasize is that when you try to address cognitive health, and I mentioned how important it was to generalize beyond just training somebody to play a game or do one particular task, you want it to generalize beyond that trained task. Physical exercise or dance is often seen as the most effective because you're not only increasing blood flow to the brain, but you're also, when people interact with their environment, it's cognitively stimulating and challenging. And some of our, I note down below that we do novelty interventions in our, in our interventions. When we, our health coaching approaches, we want to make sure we integrate all the known principles, but also that we take a holistic approach to cognitive health. And so that not only including the physical exercise, but we think about medication management, think about sleep. That has a whole lot to do with cognition and health in general. Socialization, as I mentioned before, underappreciated in the clinic and not so hard to really help out with people in the homes or nursing homes. Novelty interventions are things like brushing your teeth with the opposite hand, making sure that you walk a different way to go to the grocery store, challenge yourself a little bit. And we have a very staged approach to suggesting novelty exercises and keeping track in an action plan of how well people are adhering to their goals. And of course, the cognitive games that we had were designed for monitoring, but they also are useful at least in practicing that one type of activity, and people can improve. So back to our approach for health coaching, taking data from sensors, and it may be just the computers, the interactive video exercise, whatever. We make inferences about on several dimensions, both the indirect physiology, but also their motivations and their adherence level, and return tailored messaging to the individual themselves, as well as formal and informal caregivers and clinicians. So when you think about health coaching, it's so important to remember that health coaching interventions are most of health is really lifestyle interventions and not optimally addressed in a clinic and certainly not in the hospital. They're going to be remote, just in time, and continuous to be effective. We want to make sure that any of our modeling, our computational algorithms do incorporate variables related to health behavior change. Principles that are known to work need to be incorporated. One of the benefits of going in this direction is that you can make optimal use of lower cost personnel. Quite often people think, well, it has to be at least a nurse care manager, maybe nurse practitioner that has to be in charge. When in fact, the most important thing for most of the interactions is understanding coaching, motivational interviewing, understanding the principles of what helps people adhere to their known own goals. Many of these interventions, the protocols can be made fairly explicit with clear ideas of when to refer to up the chain to a clinician. But so often family members are not incorporated in these types of interventions. We want to make sure that they have roles and responsibilities, and these can be encoded into your software. It's a real untapped resource, as well as the patients themselves, of course. And once you have this kind of platform, it's useful for testing sustained health interventions in the home, understanding what works and what doesn't work. So the idea is that you can make effective use of your resources this way, know when to use face-to-face, video, phone, or the automated system, supplemented by automated or semi-automated messages. But we found, a lot of times people will want to do everything automated. And we found it's so important to first build rapport, get people on board, understand the initial surveys. We've made many mistakes when we compare just doing a computer survey versus at least a phone interaction, letting people talk. The misunderstandings are incredible, especially when it comes to exercise and some of the disease management. So careful assessment up front can then be supplemented in an automated way. And I'm going to describe a little bit about how important a dynamic user model is that integrates the behavior change variables and estimates health states. So I'll go through as examples a couple physical exercise, medication management, sleep, socialization, stress, and cognition. But first, just want to emphasize the dynamic user model here, which holds the current state of the patient, their current goals and motivations, current barriers and cognitive levels, and their level of adherence at the time. This starts out with an intake assessment that I mentioned that needs to be done fairly carefully, but you're assessing not only their exercise level and things like that, but also their goals, their barriers, and readiness to change. The monitored data also influences in real time the dynamic user model, which then is analyzed in order to create messages that go to the home, to the individual. So we have a message database of greetings, closings, feedback messages that get pulled out in components at the right time to then provide interfaces to the patient, give them feedback and motivation, feedback on their action plan, how well they're doing, what the results are, but also summary information for the family and coach. So at Northeastern, in our new home laboratory, we have an apartment-like complex where we do our initial testing of, in this case, you can see the robot and interactive video exercise. And so this helps get most of the bugs out of any new intervention that we have. And we've used our health coaching platform for example, in one P20 center grant that we had with the School of Nursing, to help nurses be able to use state-of-the-art technology to deliver health interventions to the homes of older adults, and without needing to know all the data requirements, data transfer, data analysis, but be able to test out new innovative clinical approaches. So I'll just go through some quick examples here. One important area was funded by NSF and for interactive video exercise, where we had the Connect camera on the top of the module and looking at the physical therapist going through the exercises on video, not real time, but stored in a storyboard form, depending on how well the person was doing, how many repetitions they were up to at the time. But we could automatically, with a skeleton image that you would see on the side, be able to detect repetitions, give them immediate feedback, help them say reach higher, whatever feedback was necessary at the time. But also then at the end, we would have a record of their current strength, flexibility, and endurance. Now, in moving to Boston, we wanted to address the needs of the minority urban community and found it was important to add interesting music. And even though we were focusing on African Americans in Boston, there were two separate groups, clearly some from Dominican Republic or that spoke Spanish, and a wide variety that would have different types of music preferences. They enjoyed a more dynamic kind of interaction. And then it was a trade-off. Do we use our carefully academic constructed interactive video with our, that we had created before, or just simply move to trying to match their exercises with the Connect camera, and also investigated the user interface designs using avatars. But it's important to think about how best to modify, or from the beginning, be able to do your design so that it's useful for a wide variety of populations. So for sleep management, we did some interesting work in first assessing anxiety, circadian rhythm issues, or sleep hygiene issues as being a problem for an individual. Then looking at the standard kinds of output from, in our case, we had bed mat from Apple and MFit we've tried as well. I think we've done more recent work with Fitbit, but looking at the standard output from sleep quality from commercially available devices, able to give tailored feedback and specifically address their issues. For anxiety, we would have deep breathing exercises, or working on giving them, the intervention would be tailored depending on if it's a very simple sleep hygiene issue. We fix one thing at a time and see if sleep would improve by the metrics from the commercially available systems. I mentioned how important socialization was. We've done a lot of work on this over the years, and in debriefing the older adults that participated in these wide variety of cognitive interventions, it was almost universal that the socialization was most important to them. We've tried robots, both anecdotally more in the home, but in the midst of a study right now where we're looking at robots in nursing homes where there's a remote family member unable to visit routinely with the individual in the nursing home. This is a self-navigating robot that goes from the charging station at the appropriate time to the room of the resident, and they're able to connect, along with tailored games for them. And this is with a company called Vigorous Minds that has the ability to provide tailored images, music, and they are now looking into using, as I mentioned before, the Solo software for monitoring the facial expressions and adapting the music or the activities based on whether it's making them more or less anxious, more happy or sad. Stress management is another area. It's been challenging for us to do these algorithms and get them reliable. And again, as I mentioned before, we're using heart rate variability as well as electrodermal activity to develop estimates of stress. But once you do have these estimates and you can provide insight to what's causing the stress, as you see in this diagram in the upper right, you have the ability to provide insight and feedback and an action plan for the future of how you're going to address stress. So medication management is another intervention where we have under a typical medication dispenser, a webcam, and we were able to successfully show that family members could help with both the dispensing and keeping track of when medications were taken properly or not. And we've tested out phone interfaces to indicate that. For example, this red alert here for medications. So this kind of summary information can be useful for families, informal caregivers, and then we're working on separate kinds of interfaces for clinicians. And I'm going to wind up just saying that this kind of approach is scalable, extends the reach of clinicians, and incorporates family and patients into the care team, timely and continuous, with an overall aim of improving quality of life while making it scalable and lowering costs. So I'm realizing now we're over time, so I'm going to just quickly mention that it's important to integrate patient preferences and social circumstances into the dynamic model for the user in order to provide true precision care. Let me just thank the people that have contributed to this work and take questions right now.
Thank you very much, Holly. That was great. Took copious notes because there's so much information and ideas in there. And I'm going to ask one question that was posed during your talk and then open it up to others. There was a question that was posed early on when you were talking about some of the work at OHSU, and that is how varied are the patterns and responses between participants, and conversely, how well did your models generalize to multiple individuals?
Well, the whole point of this kind of modeling is to tailor it. And yes, you know, one thing I didn't bring up where there was some variability that we didn't quite expect is in the area of privacy concerns. The part that was very ubiquitous with older adults is that they wanted to trade off their data for benefit. But for example, their adult children couldn't understand why they were giving up their sleep data that could be viewed as very private, or their cognitive data that's very sensitive. But as people progressed in the trial, they became more and more savvy, still wanted to give up the data. But where we found there was important variability that we needed to remodel is to have role-based privacy sharing, and not even just role-based, but say family members are able to see something. Well, it turned out quite often there would be one adult child they'd want to share the data with and absolutely not another one. So we need to be able, that was one area where there was some diverse preferences that we needed to account for.
All right. Thank you. And I do want to move right along with the questions because we are getting tight on time. But Alyssa pointed out she feels, and so do we, it's an impressive scope of work. And she had a question: what behavior change methods have you found successful? What do patients like most or find most beneficial versus caregivers?
Oh, yes. So Alyssa's all about caregivers, and that is a newer area for us. With regard to patients, there's so many models of health behavior change out there. I found the transactional or the health behavior, I'm trying to think of the stages of change is very, very useful for the tailoring of messages. Knowing where somebody is and knowing their stage of change puts out a certain type of message. With the part that I found most useful for actual variables is motivational interviewing. And that was so helpful to be able to understand why is somebody wanting to change and be able to reinforce that and bring it up again. So I've used those two, found them most useful.
Thank you. Yeah, that making a note. So for the rest of you, if you have a question, you can type it into the Q&A or just raise your hand icon.
Diane, I have my hand raised. I had a quick question. Holly, that was amazing. What a great body of work. There's so many different questions I could ask you, but the one that I'm really curious about is kind of those the feedback and the messages that you would give about health behavior change if you were doing like the in the moment interventions. Have there been like specific types of feedback that's helpful to give people, or what are your messages like, or how did you figure out what were the best messages?
Oh, that's been a process. It's been, an interesting process where, in the beginning, I would be the one to come up with kind of crude messages that were kind of obvious, but we would then have health coaches in turn fix them. And one of the biggest lessons I learned is always be positive. You don't tell anybody that they're wrong or not doing well. In fact, there's been so many technological problems. We would often think people, well, you're not recharging your device, you're not wearing your device, when in fact, it would sometimes be our fault. So we learned ways of softening, making sure we're not blaming people and trying to keep them engaged. It's very tricky. But I think, just the feedback on how well people are doing, and we focused on their adherence as opposed to any actual measure, and gave them encouragement and congratulations about being able to adhere to their action plan.
Thank you.
So Hallie, one of our audience members is Asifag Gebermedin, who is faculty in computer science, and he has a question that I'm curious about also. He says, thank you for a very interesting talk. He has a question on the linguistic analysis work that you mentioned, where there are slow and subtle changes in cognition, that they're compensated and hard to detect.
Yes.
So can you speak more about what is done specifically in terms of the linguistic analysis work for this? So is it done using natural language processing techniques or some psychology-driven methods?
Oh, yeah, that's a good question. For what we've done is just look at linguistic complexity, the complexity of words over time. That's simple. What I was mentioning for other examples, if you're going to look at schizophrenia, that's almost a machine learning type of approach. And I'm trying to think of the depression as well. You can use word spotting. Like if you're looking, some people have looked for suicidal ideation, trying to anticipate that. In that case, it's a form of the linguistic analysis where you're doing word spotting, but putting all of these kinds of features together. I'm a real fan of using as much free information that you have when you gather a data source and figuring out what the features are and knowing how to fuse that data to give you the best estimate over time. And again, the emphasis on over time. Depression for bipolar is a dynamic disease. Schizophrenia also, if people aren't adhering to their drugs, they often aren't the ones getting the benefit. It's the family members that are getting the benefit. So if you can figure out when somebody is maybe not adhering to their medication, it can be useful. Parkinson's would be voice statistics. The voice statistics that we're using for COPD are coming in a proprietary way from Samsung Research. They've developed this. We're interested in figuring out, well, can we use it for monitoring COPD over time, looking for exacerbations? But again, it's statistics about the voice.
Thank you. And SFS says thank you. And thanks again for a great talk. If there are no more raised hands, I would like to ask one last question.
Sure.
You talked about a couple times, both with work that you're about to start and other ideas about looking for trends and within subject variation. So day-to-day variation or variability, I can visualize how to quantify that, but trends, that's so much more abstract. I'm wondering how you are defining and looking for trends.
Well, the simple trend in walking speed, when you go to a neuropsychologist and they measure walking speed, well, that's once a year, maybe twice a year if you're in a study, but there's so much variability in that simple measure. If you can measure that every day, even though it's, there might be a lot of context and variability, but looking at that every day and you're looking to see how one person changes, it's a much better indicator than an occasional measure once a year. And that's true of all of these other kinds of tests that are done in the clinic, where they're comparing to a population. You can always do much better if you're looking at a change within a subject. So it's just an idea of it is the trend. And for managing these neurological conditions, you want to make sure people are getting better, or at least, if it's a chronic condition, that they're not getting worse. And in our case of COPD, we want to look within a subject. We're not so sure about this Samsung measure. It's been shown to diagnose COPD, but we're thinking it could be more useful and timely if you're able to make multiple measurements every time somebody talks on the phone. And you're getting data over time for the very same person and looking to see, are they getting better or worse?
Okay, thank you so much for your presentation, for your discussion and your time. This was great.
Well, it's
So-
very enjoyable seeing all of you, and thank you for your questions.
Yes, so we'll continue to, I'm sure, talk and hopefully work together on some of these
I would love it.
challenges.
Thank you all.
Thank you.
Bye.
Bye.